to stent or not. To stent or not to stent, the end is debate. My case, 45 years old male patient, ex-smoker, diabetic, with family history of sudden cardiac death. He developed chest pains that started 12 hours before the first medical contact and accompanied with diaphoresis and vomiting. CCU admission for non-ST elevation acute coronary syndrome. Clinical data. His blood pressure was 100/60. His pulse was 90 beats per minute. ECG show non-significant ST T-wave changes. Echo show hypokinetic apical septal and anterior walls. Ejection fraction was 58%. Troponin was positive. The patient received 600 mg clopidogrel and 300 mg aspirin and referred to cath lab. Our coronary angio through femoral axis show total occluded proximal LED with retrograde filling from RCA. This is RCA and retrograde filling to LED. And spider view show total acute LED. So BCI was planned. We used EPU catheter and sine wire, and we managed to pass the lesion bud. After many balloon dilatation using different size balloons and the intracoronary bolus of tyrosine, we found this. So the anatomy here is not clear. There is a heavy thrombus burden, and the LED fills retrogradely from RCA. What is the best strategy? Thrombus aspiration, stent, or GP2P3 inhibitor infusion. Pros and cons. Thrombus aspiration, there is a risk of stroke, stent, which size of stent, and where to land, and the anatomy is not clear, and there is a high risk of no reflow because of thrombus burden. So we picked the third option, especially the patient was stable and there was retrograde filling from LED to LED. So after 40 hours of tyrosine infusion, this was LED. This aneurysmatic dilatation in proximal LED. So what is the next step? We picked the code card. Fortunately, our decision was good. The LED showed proximally aneurysmatic dilatation with thrombus burden. The question now, which type of stent? Cover stent, self-opposing stent, or drug-eluting stent. Cover stents pros, the synthetic membrane of the stent graft effectively prevent plaque protrusion, successfully sealing the aneurysm. Cons, higher incidence of 30 days subacute myocardial infarction than standard stents, and also side branch occlusion. Self-opposing stent is another option, and its pros in ectatic tapered or aneurysmal vessel. The stent, due to its self-opposing design, is able to oppose itself all along the vessel, even in case of large diameter variation, thus avoiding malapposition. Cons, direct comparison with balloon expandable stents from large randomized trials is still lacking. So the final result, we used 2DS, 275 by 48 distally, and 4 by 23 proximally with a good final result. Follow-up. 1 month follow-up, the patient has no chest pain, and echo showed improved septal and anterior walls hypokinesia. So conclusion, coronary artery aneurysm is defined as the localized dilatation of a portion or diffuse segment of the coronary artery with a diameter of more than 1.5 times the adjacent normal coronary artery. And geographically detected coronary aneurysms represent 0.6% to 4.9%. More than 90% of coronary aneurysms are of atherosclerotic origin. Causative factors include atherosclerosis, Takayuso-arteritis, congenital disorders, Kawasaki disease, and percutaneous coronary intervention. Potential complications are thrombosis, rupture, and embolism. Covered stent implantation has emerged as a new strategy to treat this rare disorder. Another treatment option include self-opposing stents, DS, and even surgery. Thank you.
Can you go back and show us again the picture after you, if you dilate it? Go back. No, go back.
And did they have troponin? Like, was it troponin positive?
Yeah, positive, non-STEMI.
Is that okay? Can you Okay, go back one more. Is that
You want the
is that
picture of the movie?
Yeah. So what do you think? It is an aneurysm?
Aneurysmal dilatation.
Yeah. No, initially it looked like a contained rupture and large
Yes.
dissection. So that was my initial impression when I saw. So go back one more.
This was the dilemma when
Yeah. Go back.
we passed the wire. Sorry. My course
Go back.
Okay.
Yeah, there.
This one,
Yeah.
the dilatation here is vague. You don't know if you are in the true or false lumen.
My initial reaction was that that was an extravasation of contrast.
Yes.
I mean, that was my initial
Deflation.
impression.
We do also.
Yeah.
We thought this one is a perforation.
Well, because, you said you did have difficulty with the wire, number
Not difficult.
one.
The wire is bending here every time. The wire is bending
Right.
here. So my course director said you are in false lumen.
What wire did you use? If you
Scion wire.
Oh, the Scion. Okay. Well, and then this definitely was some troponin, but there were collaterals all the way from the right up. So that I'm not sure how like acute, like there was, this been there for a while or not.
Yes, chest pains started 12 hours before come to our institute, yes. So I think it was non-stem, yes. Because
So-
of retrograde filling.
And you just put a regular stent, like a drug-eluting stent at the end?
Yes, 2 tricholuting stents.
So what do you decide to do? So here you just ballooned it and
Ballooned all over the LED, but
Okay.
You have only TIMI1 flow.
And then I did 2B3A for 48 hours and then came back and
Intracoronary bolus, then we did 48 hours infusion, and then we came back. Because here we are blind, we don't know where to put the stent. Especially distal LED was diseased in the retrograde filling.
Still feel that this was the good luck for the continued intersection. Because the flow into the aneurysmal segment just doesn't flow freely like it does in an aneurysm. If you go back and follow it frame by frame, look at it, I think
Here.
were the continued
Dissection.
which thankfully did not perforate.
I don't think it is a dissection because manipulation of wires there is no resistance. Okay, and here it will be in this image, it will be clear. It is not a dissection. It is an aneurysmatic dilatation.
there's a large filling defect or it's a dissection. I mean, but in the end, after we see the pictures,
Here is a picture.
that looks like
It's an aneurysm. It's not a dissection.
Okay. Any additional comment from the panel or the?
it's a very interesting case.
Just one comment. If you were quite uncertain about your wire position, you may not have wanted to do this acutely, but you would have the option of putting in a second access and taking a shot retrograde from the RCA to try to help you determine where your wire was located and to help you decide whether to go ahead and stent or look at other
So
strategies.
if you were in my place, did you stent directly or do like I did?
No, but did you hear what she
Yeah.
suggested? That's a very good suggestion there because you don't really know if you are in the true lumen or not because you're not seeing and then you have difficulties manipulating with the wire.
The other thing I wanted to mention is that if I was sure, because I'm not, that this was an aneurysm and this is like a 40 whatever year, like a young patient, I wouldn't be hesitant and say, like to call a surgeon to do an off-pump lima to LAD and close down the lima at the aneurysmal segment so this way, or like fix that too. In the sense of, if such a big aneurysm, you're just going to put a drug-eluting stent through it and that's going to seal it.
I had a case like this before in acute STEMI, and it was inferior STEMI, and I bought a graft stent, and 1 month ago there was stent thrombosis. So
Right,
I have a bad
that's
history with
what I'm
graft
saying,
stent.
that, I would be very hesitant if I believe it's
Because he is a young patient
covered
also.
stent, definitely,
Yeah.
no, that's why
That's
I would
also a very
prefer-
good suggestion. And then you had time to decide and
Right.
discuss with the heart
Right.
team because you stopped. And I think you did the right thing about stopping and thinking through the case once you've reestablished flow.
Also,
Or, the patient had collateral flow anyway.
yeah. Also, that suggests that is the aneurysm. Look at the proximal to the aneurysm. There's very
So-
tapered,
Yeah.
tapered
What size
lesion.
stent did you put? You put a 3?
4.0 at
4.0.
proximal, and then 2.75 to the distal, and we did post-stent dilatation by 4 proximal and 3.5 at.
And you don't have IVUS in your institution?
No,
because that can always
yes.
go. Okay. So any additional comments?
Well, just that comment about taking the patient to surgery, I've had that experience where proximal LAD, you know, conceptually, we think the surgeon is going to go in there and somehow deal with the aneurysm, ligate it, close it, something, and bypass the artery. But in reality, when it's at proximal, it's kind of under the pulmonary artery. They can't get to it. They don't see it. They don't touch it. They just bypass it. And you haven't really eliminated, if you're doing it for the risk of rupture down the road, it can be unsatisfying to send them to the OR because they don't really address that problem.
But then, but it's probably going to occlude. There's
It
some
probably
sign-
is,
Yeah,
right,
there's some,
right.
It's
some.
gonna thrombose.
Yeah, it's going to thrombose, and there are still residual significant lesions
Yeah.
there.
Also, the patient has family history that his father died at 45 years, so this may be something genetics for.
Possible.
This may also suggest that it's an aneurysm, not a dissection.
Okay, perfect. So thank you so much.